It's my great pleasure to introduce Dr. Patricia Dickson, who's coming to us from Washington University in St. Louis. She's a medical geneticist and has a lot to teach us. Thank you so much for being here.
Thank you so much, Lori. That's very, Laura, very kind of you. I am going to share my screen, recognize some familiar faces in the audience. Hello. Okay, can everyone see this? Just see what you are supposed to see and not what you're not supposed to see?
Looks good.
Okay, so I run a research lab, so I have some research support from Genzyme and a company called Manna-6-phosphate, M6P Therapeutics. So you might have heard about lysosomal storage diseases in medical school or whatever, and you may have learned about mucopolysaccharidosis or MPS. Maybe you might remember some of the subtypes, Hurler, Hunter, Sanfilippo, and possibly you saw pictures like this out of WOOC, illustrating the features of the condition. Maybe you saw some stick figure biochemical diagrams showing the different glycosaminoglycans and the enzyme deficiencies that cause buildup of glycosaminoglycans and cause the disease. Or even some histopathological, either glass microscope slides, PowerPoint slides, or I don't know what they do these days to look at the features. For example, these EMs showing fluffy white glycosaminoglycans sitting in lysosomes. But really the only way to learn about lysosomal diseases is to see the patients. So I'm going to show you this video. It's about 8 years old. But be on the lookout for the different conditions. They will flash on the screen, and listen to the stories and watch the children. So this is I'm going to skip a little bit in the middle of the video, but otherwise I'm going to watch this video with me.
Austin was very happy, you know, running around, physically active.
Where's Austin?
He was just like any normal 2-year-old. You don't have this thought that there's this big issue.
From 7 to age 13, many misdiagnoses. They thought he had muscular dystrophy. They thought he had just a host of different things.
We walked in and there was like 8 doctors in white coats, and I thought, this is really weird, like what is going on? And then they said, your son has MPS.
You're scared to death, you know, for him, and you just don't know what to expect.
We had never heard of mucolipidosis. We had never heard of even the word storage disease.
Okay, so what do we do? Tell me where I need to go to get the treatment to fix it. This was my biggest thing. Let's fix this. Everyone's silent in the room. And when they say, well, there's no treatment and there's nothing we can do, in fact, the prognosis is terminal. You kind of go numb and you sort of, sorry, you don't really want to believe it.
Your body is full of different enzymes. These are the hammers, the screwdrivers, the saws. These are the pieces of tools that help you build your body and break it down. And so depending on which ones you're missing, you have a different effect on the body.
Mucopolysaccharidosis and mucolipidosis are progressive diseases. A child is unable to remove the waste from their cells. Those cells begin to implode, swell up, create storage throughout the entire body.
The heart gets bigger and their features get coarse, their lips get bigger, their airway gets bigger and coarse and tight. Their lungs get full of this stuff and it's almost like they have asthma. Their joints get restricted and they can't straighten them. And then in the brain this happens as well, and it causes progressive intellectual disability.
We don't really know what is it about the mutation or the amount of storage material that determines why someone has neurologic disease and some other patients don't.
They're born normally. They'll gain normal milestones, so your child will learn to talk. Your child will learn to walk. And then progressively lose those things.
He knew a lot of his letters, the colors.
Animal sounds. Physically was able to kick a soccer ball forever, you know, in the backyard.
In the Sanfilippo child, a lot of the cells that end up being damaged are in the brain.
When he was, about 7.5 years old, he became almost completely nonverbal. Austin's maximum kind of mental development capped out at about 2.5 years old. Now today he would score about at the 1.5-year-old level, even though he's 9.5 years old.
The parents are watching their child deteriorate in front of their eyes and are powerless most of the time to do anything about it.
Spencer did walk. He would run, played baseball, just like a lot of the other kids. Since it's a progressive disease, all of that has just, his condition has gotten worse. And he's been in a wheelchair since 3rd grade, and he's a freshman in high school now. He's got a lot of joint issues and joint pain. His hips are permanently dislocated. He's got a heart condition. He's got some problems with his lungs. Most of it is all physical. We've been very lucky and blessed that he hasn't been affected developmentally.
Which I'm about to use. I finished first!
Spencer and his sister are very close. Her role, I think she figured it out herself, has been his protector.
Sometimes when I wake up at night when my leg hurts, sometimes my mom and dad don't wake up right away, so she'll scream and tell them that Spencer needs help.
That's your ball! Go, go, go! All the way, all the way!
There you go, all the way! Help her. You can do it, you got it! I like to root for my sister when she plays her soccer or stuff that she is interested in, because she can probably go really far.
Like, even though he has that pain every day, he has a smile on his face. He's always happy, encouraging me, and I try to encourage him.
There's no treatment or cure for his condition. Unlike some of the disorders, it's just keeping the kids comfortable and dealing with whatever orthopedic or health issues that come up.
Skip a little bit. Oh, actually.
It's not a cure, but it's able to put some halting to the disease's progression.
Can you say that it's a life-saving treatment? Yes, definitely.
They both take their IV pumps back to their bedroom and they go to sleep. And when the treatment's over, they want to be unhooked so they can go to Disneyland or whatever else they have planned for that day.
It's kind of weird because the grim reality of it is that most people afflicted with this don't live past, their early 20s. So I'm now 24, and you've essentially been given a second chance, a new lease on life.
Currently, we don't have a treatment for MPS 4A, 4B, for MPS 7, for MPS 3, and for mucolipidosis.
We're specifically testing for MPS 4, Morchio 4A at this point. If the data looks good and supports approval sometime late 2013, there would be a therapy available.
The reality is that there are still some symptoms that don't respond well to enzyme, and in particular, we still have not yet treated the brain. It is harder to treat the brain than it is to treat physical disease.
What the blood-brain barrier is designed to do is to keep things out to protect the brain cells. But what it also does is it keeps mechanisms out that you want to cross the blood-brain barrier can't get in.
We're working on a way to develop an enzyme treatment using the cerebrospinal fluid as a delivery system.
That's a major issue that researchers struggle with right now.
As far as looking at pictures when they were younger, it's difficult. Russell used to smile and laugh, and he used to run. He lost his mobility about when he was 9. She's starting to now lose her mobility as well. She's not jumping on a trampoline anymore, and we had to put Russell in a wheelchair, and then about less than a year later, we had to put put him with a feeding tube because he quit being able to use the muscles, and she's starting to do that now. Everything just atrophies. It's devastating.
It is absolutely heartbreaking to know that the natural order of things is not going to be followed. That is, children bury their parents. Parents don't bury their children. And in most of these MPS families, it is the latter, as it was in my family.
As far as treatment goes for MPS 3, it's a race against time. Hoping, believing, and praying for it every day.
The mission of the National
Slightly.
Into clinical trials, but we still need to do more. Every child deserves to be saved.
It's pretty fun. Yo-yoing is a pretty good. You can do it sitting down. This one is called the Eiffel Tower.
Spencer has a very positive outlook on life, despite the challenges and the pain that goes with that.
I pray almost every day that they'll find a cure for his disease.
I really want to get a good GPA in high school so I can get to a good college and have a good future. I look forward to when they maybe find a cure, and but that might not be for maybe many years, but I'll try not to let that stop me and stop me from achieving my goals.
Rare diseases have this tremendous disadvantage that very few people have them, and there's very little public interest in them. And so you're always fighting an uphill battle.
You know, it's not like treating cancer or diabetes where there's millions and millions of people.
But with these rare diseases, we have a chance to do something profound and meaningful to transform lives. We could be doing more with the science we already have.
We won't stop fundraising until there's a cure. My daughter is going to be faced with these choices. She's going to potentially have a child with MPS, and I want her to know that even if she has a child born with this gene, that's okay, because we have a cure for it, honey, and don't worry.
So when I was a fellow in 2004, I got into MPS really kind of almost just by accident. I was at Harbor, and that's where Emil's lab was. But I rarely saw any patients. I didn't really know much about it. And I had gone to a family conference at Disney World, and Joe Munzer was there, studies MPS 2 in North Carolina. And the lobby was just crisscrossed with people in scooters and wheelchairs and just walking around and talking. And I said, show me the patients with MPS, like what are all the MPS types? And he walked me around the room and just showed me what the patients were like and what each condition was like. And that's how I learned MPS. So, but when you're seeing, patients and you want to figure out, what is lysosomal, and a lot of the patients who you saw, the children and adults you saw in the video have a Hurler-like presentation. So what does that mean? It means coarse facial features. There's often organomegaly. So I know the art of physical examination is fading. But if you look and you see abdominal distension, particularly with an umbilical hernia, start down in the pelvis and feel up and try to see if you can palpate organomegaly. Use the scratch test. It's very helpful to try to find that. Hypertrophic cardiomyopathy, valvular stenosis and regurgitation. So they tend to get a lot of storage material inside the valves of the heart. And so those valves become both stenotic and regurgitant. Leukodystrophy is seen in a number of lysosomal disorders because they affect myelination. And so leukodystrophy is a sign of demyelination. So you often see progressive white matter changes in some of the different lysosomal conditions. Corneal clouding, retinopathy, glaucoma, multiple joint restrictions, including the fingers. So they wouldn't be able to fully straighten the fingers. They lose range of motion basically, and they can lose it in all the joints. With some, you know, some don't have that presentation. And then the other thing is just to note that these are progressive, right? Signs and symptoms of lysosomal storage are progressive because the lysosomal storage is progressive. And then for the skeletal system, there's a term called dystosis multiplex. So what is dystosis multiplex? So I was a classics major, and I often find that my Latin or Greek becomes really handy so I can translate things and it helps me define what they are. This term basically means a bunch of bad bones. So it's not at all helpful. But dystosis multiplex consists of platyspondyly, which are these oar-shaped ribs, coxa valga, which has to do with the angle of the femoral neck and the femoral shaft, larger than it should be expected. Femoral heads are often dysplastic. In the knees, so genu, that's Latin for knee, the knees have genu valgum. Vertebral bodies can show hypoplasia, anterior wedging or beaking. And then bones just irregularly shaped, basically everywhere, including what's described as bullet-shaped phalanges. Long bones tend to be short and wide. Clavicles are short and wide. There's a lot of more specific findings, but this is generally what is described as dystosis multiplex. So we saw some individuals with MPS 1 and 2, and all of these have ranges of severity. So the severe form of MPS 1 is referred to as Hurler syndrome. You have very early onset. You should see some sort of symptoms or signs onset in infancy. The physical features have that Hurler-like presentation that I described. And there's central nervous system involvement with Hurler syndrome, including hydrocephalus, cognitive impairment, cystic cribriform lesions in the brain, and they can also get spinal cord compression, which we'll talk about, which is common to other conditions as well. There are attenuated forms of MPS 1. The milder or less severe form is Shea, and then Hurler-Shea is intermediate between Hurler and Shea. It's not really relevant anymore. Just call it attenuated MPS 1. Varying degrees of CNS involvement. It can be non-existent or just scoring, slightly below standard on different domains, and later onset. And then MPS 2 is Hunter syndrome, X-linked inheritance, can be severe or attenuated, neuronopathic or not. We saw severe Hunter syndrome in the video with Dr. Harmatz from Children's in Oakland. So other mucopolysaccharidoses with skeletal manifestations. Meritolamine was also shown in the video, much more physical features, very Hurler-like, but not the CNS disorder. So they tend to have normal intellect. Sly syndrome, MPS 7 is very Hurler-like. Morquio A and B or MPS 4 is different. They only store keratan sulfate, so they tend to get more in the way of a skeletal dysplasia and less, although not no physical disease. They still do get poor endurance from pulmonary problems. They can get cardiac manifestations. They get splenomegaly to some extent, corneal clouding they certainly get. And Morquio A, there is an ERT now, and that video again was old. And no CNS involvement. But the big thing with them, instead of seeing joint restrictions, you tend to get ligamentous laxity. I've even seen so much play at the knees that they have difficulty walking and then no stability at the knee because of the tremendous amount of ligamentous laxity that they have. And then also spinal instability. And then Sanfilippo was also in the video. They tend to not present with orthopedic manifestations. More slight coarsening of the features, which you saw, and central nervous system was predominant. There's a number of other lysosomal diseases that causes Hurler-like presentation, the MPS as I described, the mucolipidosis, so ML3 Spencer, and it's the one with that I didn't do it on his t-shirt, had mucolipidosis type 3 alpha beta. There is a gamma subunit to that enzyme. It's the enzyme that puts mannose-6-phosphate on the other lysosomal enzymes. So mucolipidosis, both ML2 and 3, when you do the enzymatic assays in blood, you just see a bunch of enzymes that are just spilling out into blood because they're not trafficking correctly to the lysosomes. So ML3 alpha beta is just a milder form of mucolipidosis 2. There's an ML3 gamma, which is the gamma subunit. Those patients present much more subtly and can be missed for a really long time with joint pain. And they will have dystosis multiplex if you x-ray them. Glycoprotein storage disorders like fucosidosis, mannosidosis, sialic acid, galactosialidosis, multiple sulfatase deficiency, those can all give you that dystosis multiplex phenotype. Get a lot of complaints from patients with just pain and poor endurance. Some of that can be from pulmonary involvement. Some of it can be spinal cord compression. Some of it is they have so many joint restrictions that it's difficult to ambulate, and they have a lot of trouble just physically compensating for their poor range of motion and balance issues, that it causes a lot of difficulty with endurance and walking, getting around. Joint laxity, I mentioned, a lot of kyphoscoliosis and gibbous deformities and spinal deformities from the vertebral problems I showed you. A lot of hip problems, hip pain, very, very disabling, hip dysplasias. And then cord compression. So this is generally cervical, but it can be at any level. And it's a combination of bony canal stenosis with dural thickening. Here, what you see in a T2 weighted image at sagittal, you see a complete loss of the CSF cushion around the cord at these levels. So you see the bright CSF line here. You see it up here, but you don't see it here. You also see here compression of the cord where it's thinner, flatter than it should be on axial view. And this arrowhead is showing a bright signal within the cord. That's edema, or signal change within the cord showing edema. So that's a very severe cord compression. And some of the symptoms that people will describe, they will describe for me pain in the legs when walking, fatigue in the legs when walking. They may have urinary or fecal incontinence. On exam, they'll have hyperreflexia. I've seen diaphragmatic paralysis from this. And some of them, in addition to compression, have cervical spinal instability and particularly a problem for Morquio. Some of them might be in rheumatology clinics. Maybe they got a diagnosis of polyarticular juvenile idiopathic arthritis at seronegative. And they don't generally present with carpal tunnel syndrome, but they certainly can get carpal tunnel syndrome. It's very important, particularly for your nonverbal children, to screen for this. So there are a variety of fantastic reviews by people who know a lot more than me about the skeletal manifestations of lysosomal disorders. I have in my last slide for you like a list of some of them, but this one is great. Has a nice overview of the different types of MPS and which manifestations they tend to have more of or less of in skeleton. And okay, so diagnoses. So diagnosis of genetic disorders is changing all the time. And lysosomal disorders, now a lot of states do screening for some lysosomal disorders, but some of them are not screened for, and it varies very much by state. And then, of course, you have to think about when your child was born and if they were born prior to when that screening happened. So one option is a lysosomal enzyme panel. So this is generally done on blood, looks at leukocyte activities of enzymes or blood and leukocytes. So the problem, though, with lysosomal enzyme testing is, first of all, there are some pseudodeficiencies. So all of the substrates for these enzymes are artificial substrates. They're not the natural substrates. And so you can get a pseudodeficiency, which means that there's a measured deficiency of the enzyme, but it doesn't actually cause any disease. Lysosomal enzyme panel, of course, wouldn't catch the lysosomal diseases that are not due to enzyme deficiencies. Some of the enzymes are not on the panel. For example, Dr. Wenger doesn't like assaying sulfatases. They're not fun. It's a two-step assay. So, you know, it's not he puts them on the panel. He kind of tailors it to what the clinical features are, but some of them are not on the panel. There can be specimen handling issues because their enzymes or activity is very sensitive to freeze-thaw issues and heat and that kind of thing, or any technical issues with the assays. Some of the substrates have a lot of background, for example. Then you could look at urine. You could look at urine for substrates like glycosaminoglycans for MPS, oligosaccharides for your glycoproteinoses and other things, sulfatide for MLD, X4 for Pompe, et cetera. And this is very, very good. This is some of the problem is that there are, first of all, it's more focused because you can't just say, I want urine for all the substrates of all the lysosomal diseases. It doesn't cover all the lysosomal diseases, and it may miss some cases. There's some cases of MPS 4, for example, maybe even MPS 6, MPS 3 is notorious for missing, having, potentially normal urinary GAG. And then molecular diagnostic testing. So this is obviously becoming more common, right? So you can do this by single gene testing, by panel or whole exome sequence. And of course, your big drawback is variants of uncertain significance. And your slightly lesser drawback is you don't know how severe that you just get genotype information. You don't get any phenotype like you do with biochemical assays. So here's a partly hypothetical case. So a male infant screens positive for Hunter syndrome. We started doing that in Missouri with low iduronate 2-sulfatase activity on a dried blood spot. And so the kid got brought back. The iduronate 2-sulfatase activity was confirmed to be low. Urinary glycosaminoglycans were at the upper limit of normal, but normal. And the molecular testing of the IDS gene was a male, so there's only one variant, and it was not previously reported. And the reference lab classified it as likely pathogenic. Physical examination was normal. So would you diagnose Hunter syndrome? Well, it turns out that this laboratory had used the low iduronate 2-sulfatase assay as functional criteria to determine that this is a likely pathogenic variant. So ACMG variant interpretation guidelines allow you to call likely pathogenic when well-established functional studies show a deleterious effect. Well, it's deleterious, enzyme activity is low. And then it has to be either absent in population databases or de novo without maternity and paternity confirmed. So you could have any criteria, any one of these 1 through 6 criteria, and you meet the likely pathogenic threshold. So as it turned out, this child, we repeated the urinary glycosaminoglycans, which it did the non-reducing end assay, ARUP, and it was normal, and we closed that case out, partially hypothetical case. This was a study done in 2016 following the 2015 ACMG laboratory variant interpretation criteria. It's a sobering study. You can pull it up if you want. They looked at 9 different reference laboratories, and then they gave them variants to call. And there was only 34% concordance across laboratories for these applying these criteria to the same variants. And so here's that graph showing 34 of them are the same. 44% of those differences may not affect medical management, with 22% of those differences, for example, classifying something as pathogenic versus a VUS or LP versus VUS, would be expected to affect medical management. And this isn't just a newborn screening problem. So another semi-hypothetical case, a 3-year-old boy presenting with autistic features, developmental delays, and some language regressions. They thought he looked a little coarse. They did whole exome sequencing. They found a W402X known pathogenic variant and a previously unreported missense variant classified as likely pathogenic in the IDUA gene. They were in trans. The report says the results are consistent with the diagnosis of MPS 1. Leukocyte iduronate A activity was low. Urinary GAG was normal. Didn't have MPS 1. So there are other lysosomal disorders besides MPS. I don't study them, but Here are some of them. Gaucher, which generally is a disorder of macrophages. And so you get bone marrow crowding and other problems with the macrophage lineage cells. So lytic lesions from that, osteonecrosis, osteopenia, and bone pain. Niemann-Pick AB is another monocyte macrophage disorder, but mainly gives you osteopenia and pathologic fractures. Everyone forgets about cystinosis. Cystinosis is a lysosomal disease, and it causes renal Fanconi syndrome. So those patients can get hyperphosphatemic rickets. Pompe disease is a neuromuscle problem. So they get the problems that you see in patients with neuromuscle disorders. And then other leukodystrophies and CNS lysosomal disorders. So these are neurological problems and whatever bone and joint disorders that you would see in people with progressive neurological conditions you see in them, in those patients. And that's it. This is the promised for list of resources. I'll leave it up for just a second. And that's all the slides I have.